Now, in order to generate a little bit more force, I've created a fulcrum from a rolled up towel. And I'll ask you just to place that under the arm here, just as high up as we possibly can. And what this does is it provides a bit of a fulcrum just to allow us to slightly distract the joint. And then we can come onto that trigger point there. So that allows us a little bit more. If you need to generate more force with a really complex or a stuck case, you can use a two-person technique, and my colleague James is going to help me here. And what we're going to do is we're going to ask James to hold on to the wrist here and pull down a little bit that way, so it gives me some distraction of the joint. And again, from here, and if you do that with two hands, it's probably a bit easier. What I want you to do is just to sort of find the center point, just close your eyes and just feel through it so you've got it. And from here, then I'm going to apply a little bit more force onto that upper extremity, and it's a kind of balance, a sort of bit of a tug of war between the two of us, but obviously bearing in mind this is for a really encapsulated case where you can feel that you need to get a little bit more force in. And again, we're just going to run up the joint and pause a little bit underneath. Modification for the lateral trigger point. Again, we've had the patient on her side. Now we can turn the patient onto her back, and we can look at the lateral trigger point in this direction. What we can do is try, if possible, to get her to pop her hand on her tummy, just sort of internally rotate the arm. And this time I'm coming into that same trigger point, that same one where we were with you on your side, but we're going to come into it in this way. And this just allows us to, again, get that shearing force through the joint, to push a little bit deeper in and to really work that trigger point here. Again, pausing and holding on it, waiting for it to change, getting the patient to breathe and relax, and waiting for it to change there. Okay, we've got the patient lying on her tummy, and we're going to do step 4, posterior. So the first thing to say is that it's important to support the patient's arm fully. Some people you'll find won't be able to actually take their arm off the side of the bed. They'll find it very difficult, so you have to be very careful. Again, what we're looking for here is we're going to trace the triceps up until we feel it come into the posterior part of the capsule. I'm actually going to start with it quite near the top. Take the arm off if you can, and that allows you just to give it a little bit of leverage here, and what we're going to do is slightly abduct, and I'm going to trace it up, and I'm pushing through towards her left ear. I'm really pushing in here, and what I'm on is basically the subscapularis tendon. I'm on the triceps and the posterior part of the capsule, and you'll feel that quite thick, quite tight. So we're going to push in here. Can you feel that there? Okay, I want you to breathe that through, and we might have to go quite deep sometimes with that one, just to really get that working. Again, the idea is that I'm going to take the strain away from the muscle by pushing it at the same kind of pressure as it is in spasm, and then gently come away from it once we feel it giving. Now, it's very important also that when you come away, you tell the patient first, especially if they're acute. So I'm just going to take my arm away, my pressure off gently. It can go into a slight spasm in the biceps, curiously, if you come away too quickly. So I'm just going to come away there. Thank you, that's great. And I'm just going to lift your arm back onto the bed just to complete that. Again, what we're going to do here is we can work in the triceps itself. We can do a little bit of soft tissue work into the triceps, and we can trace all the way down. Now be careful as you drop the arm off not to make a spasm, but we can follow the triceps all the way up, and we can go for the different heads of the triceps. So we can either come medially, we can come centrally, or we can come laterally, and we can work our way up under the deltoid there, trace it all the way up to the posterior part of the capsule. Now, what we've done here is we've turned the patient onto her back again, and one of the further modifications we can do is, if the patient can allow a little bit of abduction, they normally can, is to have a look at the pec minor muscle. Now interestingly, when you get the trigger point through the pec minor, the pain is felt in the triceps, and that's what we're looking at, kind of triceps tendonitis. So the modification is coming into the pec minor and just holding through, and it's just by the coracoid process there, and just fixing there. And what happens is, as you come into that trigger point, you can, as you press down, you've got to find the right angle, the right sort of aptitude to get into it. Is to feel there, and the patient will say, yeah, I'm feeling that into the back of my arm. So ask the patient whether they're feeling it into the back of your arm. Again, they won't feel it if there's not an active trigger point in the posterior part of the capsule. This time we're going to drop the arm, and I'm coming from the opposite side here, and I'm going to support it, and we're aiming at, again, our pressure. You can see where you've got some slight reddening here, into this part of the arm, feeling the subscapularis tendon, the bit of the triceps, the bit of the rotator cuff, and again pushing inwards this way. I'm kind of hooking underneath the scapula a little bit and pushing inwards towards the left ear. Again, just to support it, and you can just modify the internal and external rotation of the joint, and you can really feel it if you internally rotate and just press down and then hook up and then push in there. It's a very powerful technique for the rotator cuff. It's also a good modification for the posterior capsule. And breathe and relax. Again, you may need to hold this up to 5 or 6 minutes sometimes, just to get that full release through the back of the joint. Terrific. Again, perhaps when you come off, just let the patient know, just in case there's a slight spasm, and just gently, passively bring the arm back by the side. Thanks. What we're going to do now is to, with the patient, we're going to work into the biceps tendon, the long head of the biceps. Now this is a really crucial part of the technique, and it's important that you get this right, because especially in the early phases, phase 1 and 2, it can be extremely tender. So first of all, again, just introducing your hands here, I'm just going to work a little bit of Nivea into this, or a little bit of cream into it. Again, thinking about your hand hold. Sometimes a patient can't internally rotate or externally rotate too hard. So if we leave the hand here, and what we're going to do is we're going to work up into the biceps tendon long head. And what you'll feel is nodules starting around about here, just as the sort of muscle becomes tendon. And I want you to pause on those nodules and get you to think about your breathing. And again, when we've released that one, we can come on to another. And as we approach the transverse ligament of the long head of the biceps, there's a really tender part that comes up here. And again, it's just important that you pause long enough to allow that to release. And again, we're looking for a fair amount of pressure, but a kind of mutual pressure where it doesn't feel too uncomfortable for the patient, and it feels quite comfortable for you to rest. Notice I'm not pushing, I'm sort of leaning, just resting on the point. And if I want to push, just sort of lean a little bit heavier, because you're doing really well. Breathe it through. Terrific. Okay. What we can do now is we can hold the hand in this position, or slightly abduct it as we work up. There are 3 directions in which we can work on this biceps long head tendon. We can either go what I call a central bowstring, which is straight up the middle of the tendon. It's a little bit more difficult because what you're doing there is, because it's really quite inflamed, you don't want to slip off of it. So it's really important that you take that nice and slowly. But again, you're coming right into the center of the biceps tendon as you're rolling up towards the top, and you're pausing just here, just under the tip of the transverse ligament, and holding onto it there. Modification 2 is coming slightly lateral to the long head of the biceps, and we're pushing medially. So this is what I call a medial bowstring technique, and at this time we're coming up to the side. Again, you may find this useful just as a modification if you can't get to it another way, or if a case seems to still have a little bit of biceps inflammation after they've had a couple, 2 or 3 sessions, it's not going away. Again, you can come just almost hooking behind the long head of the biceps and pushing it inwards that way. This is much more effective again for coming in to the sort of lateral part. Similarly, we can do the same thing but medially. I don't do this very often, but it's a useful modification to know, where we come into the medial part of the long head of the bicep, and this time we're bowstringing laterally. So we're coming in, finding the long head of the biceps, hooking underneath it from the medial side, and just taking it out there. And again, holding those trigger points, pausing on them, getting the patient to breathe through. Wonderful, and working them that way.